the abdominal aorta and the great vessels. The first, the abdominal aorta. The topics are mentioned for covering in this presentation. The abdominal aorta is largest great vessels. It is a largest artery in the abdominal cavity as a part of the abdominal part of the aorta. It is a direct continuation of the descending aorta. It began at the level of the diaphragm, piercing the diaphragm at the level of the T12. It has traveled down to the posterior abdominal wall, anterior to the vertebral body, and it is follow the curvature of the abdominal lumbar vertebra. That's the greater complexity is at the level of the artery. It's transparent to the inferior vena cava and located just to the right of the and becomes smaller in dimension until it is bifurcation. It is bifurcated at the level of the lower border of the L4. It is about 12 centimeters long and 2 to 3 centimeters in diameter. It is bifurcation roughly. It is at the level of the line between the two iliac crests and 2.5 centimeters below the umbilicus. It is enter the abdomen with the thoracic duct and azygous vein are accompanying the thoracic the aorta into the abdomen. Clinically, abdominal aorta is divided into the suprarenal and infrarenal part. The suprarenal one is from the diaphragm until the origin of the renal artery, while the infrarenal one is from the renal artery to its bifurcation. Clinically, it is important. This classification is important in the case of the presence of the abdominal aortic aneurysm, where it should be determined this above or suprarenal or infrarenal, because it is subsequently important in the management and management and the management of the renal in the management of the aortic aneurysm, because most of the suprarenal one are involved in the renal artery, while in lesser degree the infrarenal one involved in the renal artery. And it's also determined the way of the management. The suprarenal one is usually managed by the open repair, while the infrarenal one is mostly managed, treated with the endovascular treatment, and the subsequent complication of the renal artery are more common with the infrarenal one, and causing the renal artery stenosis and subsequently the renal impairment. The relation of the abdominal aorta in the abdomen, posterior relation is simply it is the body of the lumbar vertebra and the small lumbar veins, while anteriorly it is more complicated. The pancreas are both antecedent and body of the pancreas are located in the anteriorly, and both superior and superior third part of the duodenum coil of the small intestine are also present. The splenic and left renal vein, this is the renal vein, and this is the splenic vein, are present anteriorly. The superior mesenteric vessels, artery and vein, superior mesenteric vein and artery are in its anterior relation. Again, this is a sagittal view. This is the pancreas and senate and body of the pancreas, and it's represented in there's a pancreas, it's a left renal vein, and this is a left renal vein are also present in this one. The coil of the small intestine, duodenum, and also there's the small intestinal coil and duodenum also seen. In the right, lateral relation, in the right, there's inferior vena cava, which is removed in this picture, cisterna chyli, right crest of the diaphragm, and then also in the left side, there's a left psoas muscle and the left crest of the diaphragm. Also, the sympathetic tongue aorta is sympathetic tongue in the left side is present as well, and the inferior vena cava in the right. There's a lot of branch in the abdominal aorta, and most of them are many classification, while the simple one is this one. There's a 3 anterior unpaired branch and the 3 lateral paired visceral branch, while the with 5 lateral paired, the anterior 3 branch are celiac, superior mesenteric, and inferior mesenteric arteries, and the lateral one are the visceral, gonadal, adrenal, renal, and gonadal artery. Also the lateral paired artery, inferior phrenic, since there's 2 inferior phrenic artery, and the 4 paired lumbar arteries are in the lateral one. It terminates at the common iliac artery and median sacral artery as well. It is radiologically, it is usually it is not visible in plain radiography. Usually it's not visible in plain radiography. Only if it is calcified, it's seen at a linear calcification vertically in the midline and to the left, slightly to the left. Tortuosity of the abdominal aorta in the elderly patient with calcification will cause sometimes some diagnostic dilemma, and proximity of the aorta to the vertebral body, sometimes we may see the secondary sign as in the vertebral erosion in case of the abdominal aortic aneurysm. This is the case of abdominal aortic aneurysm and with calcification. On the lateral side, if you see this lateral view, there is a destruction of the anterior and the superior endoplate of the L3, while there is just abdominal aortic calcification with no significant or obvious paraspinal or soft tissue mass. Later on, later on, the CT scan will then show that a large abdominal or infrarenal abdominal aortic aneurysm with rupture below the renal artery, causing the erosion of the vertebral body. Ultrasound is one of the modality to examination of the abdominal aorta. It is non-invasive and simply used. Usually, it is used for the screening of the abdominal aorta, especially for the man over the 16 of the age and with smoker, and anyone with family history of the abdominal aortic aneurysm. It is fast and inexpensive, with no radiation, no intravenous contrast, sensitivity and specificity reaching about 100%. But sometimes the bowel gas and personal habit will preclude proper examination of the abdominal aorta. It can be solved by putting the patient to the right side and to overcome the bowel gas. It is usually it is visualized posterior to the pancreas, when the celiac and superior mesenteric branch can be easily seen. It is diameter about 2 to 3 centimeters, depending on the age, and it progresses gradually. The disadvantage of this, in this case, in the ultrasound, is not get many information about the exact complex mass or any complex lesion of the aorta, and cannot assess the distal branch of in case of the abdominal aortic aneurysm. This type of the aortic aneurysm, fusiform, circular, and there's the bulging of the posterior wall of the aorta with the dumbbell type of the aortic aneurysm with intramural or intraluminal thrombosis causing significant narrowing of the lumen. This is ultrasound can determine the many type of the aortic aneurysm. Also, can be easily differentiate the inferior vena cava from the aorta, because both in the abdominal aorta is posteriorly located and posterior to the diaphragm, while the IVC is more located posterior to the portal vein and the liver, and in the upper end ventrally curved posterior, grooving to the posterior part of the liver and piercing the diaphragm. The computed tomography, it's other modality for examination of the abdominal aorta. It is multi-slide CT angiographic technique. Contrast bolus is given at the 4 to 5 milliliter per second, and rapid scan acquisition in the arterial phase is taken. Tiny branch of the aorta can be identified. And that is usually axial acquired data can be displayed with the angiographic reformer. Magnetic resonance also another modality for the examination of the abdominal aorta and its branches. It is generally a group of the technique based on the magnetic resonance image to image the blood vessels. MRA is used in generally image of the arteries, but to lesser extent the veins. Usually it is used for the arterial examination of the head and neck, chest, lower limb, and abdomen. It is usually used for evaluating the stenosis, occlusion, or aneurysm, or other abnormality. Selective angiography is, or digital subtraction angiography is the one of the best modality to best image by the aortography or selective angiography, best seeing all detail of the aorta and its branches and even until that is terminal branch. And one of the advantages it is also easily seen visualized blood vessels in a bony or a dense soft tissue, because it is subtracting the soft tissue and surrounding tissue. For this, all the branch and terminal branch are easily and well obviously seen. The second part is the inferior vena cava. The inferior vena cava is the largest vein that carries the oxygenated blood from the lower and the middle body of the body into the atrium of the heart. Has a longer course in the abdomen than the aorta. It began at the biunion. It's formed by union of the right and left common iliac vein at the level of the L5, posterior to the right common iliac artery. It passes on to the right of the aorta as far as to the level of the T12. It bears the diaphragmatic tendon at the level of the T8, open the atrium at the level of the 6 costal cartilage. It has no valve, only incomplete semilunar valve as it is open. Relation anteriorly, from below upward, the coil of the small intestine and the root of the mesentery here, third part of the duodenum, pancreatic head, and the common bile duct, which is grooved posterior to the pancreatic head. The first part of the duodenum, omental epiploic foramen, and the portal vein in it. Posteriorly, there's a body of the vertebra, part of the suprarenal gland, right inferior phrenic artery, right suprarenal artery, right renal artery, and the lumbar artery, small lumbar artery, and sympathetic trunk as well. The lateral relation of the inferior vena cava in the right, there's psoas muscle and the ureter, right ureter, and abdominal aorta in this left side. The inferior vena cava has many tributary. It is generally just formed common iliac vein. From the union of the common iliac vein, each common iliac vein are formed in front of the sacroiliac vein, iliac joint by union of the internal iliac vein from the pelvis, and the internal and the external iliac vein contributed by the continuation of the femoral vein, which later entered the abdomen and the lateral side of the corresponding artery. Two common iliac veins are continue upward and unite at the level of the L5 and posterior to the right common iliac artery. The many tributaries are enter directly to the inferior vena cava. The third and fourth number vein directly enter the IVC, while the first and second number vein are to the azygos and iliolumbar vein. The fifth one are to the iliolumbar vein, subsequently to the common iliac vein. In the right side, right gonadal, right renal, right adrenal are and small vein on the right caudate lobe are entered to the directly to the IVC. There are right inferior phrenic vein as well. The left one is the left inferior phrenic is entered to the left adrenal vein, and then to the right to the left renal vein. Subsequently go enter into the IVC. It is simply, I like to write so high: iliac vein, lumbar vein, testicular vein, renal vein, suprarenal vein, hepatic vein are the major contributaries of the IVC. Few words about the its development. It is somewhat complex, but I will try to simplify its development. Generally, the IVC is formed from the three set of the vein, anterior and posterior cardinal vein, and subcardinal vein. The anterior and posterior cardinal vein are, the anterior one is draining the cephalic part of the fetus, while the posterior one is draining the rest of the body of the fetus. These sets are nearly identical in both sides, are similar in each side. It is developed at the first week of the embryologic age, and the anterior and posterior form the common cardinal vein and runs shortly distant to form the sinus venosus. Later on, the sinus venosus is forming them, developed to the primitive arteria, primitive cardia, bulbous cardus and truncus arteriosus. Later on, developed to the cardiac outflow, and this is called the heart tube. The anterior and posterior the anterior and common cardinal vein on the left side give rise to the brachiocephalic vein and subclavian vein, which is drained to the superior vena cava later on. The subcardinal vein and has an anastomosis in the middle one. This is subcardinal vein. This is the middle anastomosis, and subcardinal vein is called subcardinal venous anastomosis. The subcardinal vein have also connected to the posterior cardinal vein. This also connects. Also, subcardinal have anastomosis with each other in both sides, and also the posterior cardinal vein, also connected to the posterior cardinal vein from the anastomosis, which is referred to the mesonephric shunt. This is later on become mesonephric shunt. This is the mesonephric shunt. There is a tiny, this inferior part of the cardinal vein on the left side starting to degenerate. The lower part of the posterior cardinal vein start to degenerate, but still there will be connection with the subcardinal and posterior cardinal vein. This is called mesonephric shunt with a small projection, which is called spermatic vein. The subcardinal vein on the right side separated from the posterior cardinal. The subcardinal vein from the right side was separated from the posterior cardinal vein, and are joined to the hepatic part of the it's referred to the subcardinal. This is supracardinal vein, and subcardinal supra is called supra. There is subcardinal anastomosis, and this anastomosis forming become a part of the IVC, and later on give rise to the renal artery. This is a renal artery, and the gonadal artery and the gonadal artery as well. As general, and it is gravity. The iliac veins, the common iliac veins are derived from the distal. It's from the most inferior part of the IVC, the forming anastomosis between the posterior cardinal vein and the posterior cardinal vein, while post-renal segment is from the supracardinal vein. The renal segment is one of the most important one. It arises from the mesenteric shunt on the right side, and there's some from the result anastomosis between the subcardinal and posterior cardinal vein, forming the renal artery and gonadal artery also, and suprarenal artery as well. And subhepatic segment of the IVC is from the hepatic segment, and the hepatocardiac channel terminates the part of the. Because of this complex origin of the IVC, there will be a lot of congenital anomaly in each part of this segment. I will mention some of the anomalies. The first left-sided IVC, it is just result in the regression of the right supracardinal vein with the persistence of the left supracardinal vein. Regression of the right supracardinal vein in the right side will regress. Normally, should be the left one will regress, while in this case the right one will regress, and the left side become the left side inferior vena cava. The second one is double IVC. It's caused by the persistence of the both suprarenal supracardinal vein. Both are remain after the level of the left renal vein, and then subsequently go to the right and continue as the right side of IVC. The azygous contribution, it's failure to form the right subcardinal and hepatic anastomosis, and this will continue at the last to the this is the azygous being continued to the intrathoracical. The other modality circumaortic left renal vein. It is result in the persistence of the intersupracardinal anastomosis. The intrasupracardinal anastomosis will be persist, and there will be the circumaortic left renal vein. Retroaortic left vein, it is the persistence of the intersupracardinal and regression of the intersubcardinal anastomosis. Radiological radiology of the IVC, chest radiography, it is of a limited value in the examination of the inferior vena cava. It may be just visible in the right cardiophrenic angle and also in the left side. The cavogram is the one important modality in the examination of the inferior vena cava. The IVC can be opacified by the contrast stimulus introduced either to the both dorsal pedal vein and both feet, in both feet via the both femoral vein, or by the catheter introduced into the vein itself. This is the vein itself. Some contrast will be introduced into the tributaries by performance of the valsalva during the placement of the caval filter. Should be inputted during the caval filter. It is important to put because to prevent the embolism, and should be put below the level of the renal vein. And also should be examined to see whether there's any IVC anomaly or during the placement of it, to prevent the pulmonary embolism and establish the street does not persist to the left side. If there's, you should ensure that there's the left side or any anomalies of the IVC, because if there's anomaly will be causing the pulmonary embolism. This can be including the renal vein should be identified, as I said, because of the venal caval filter should be put below the venal origin of the renal vein. It is used the low osmolar contrast media. About 40 milliliter contrast is used for this examination, 20 milliliter by pump injection or per second by pump injection, or recorded rapid serial radiographic image. It's indicated to demonstrate the obstruction or any anomaly, or preliminary examination of the intravenous technique, or any congenital anomaly is present. Again, the ultrasound is useful examination is used for the examination of the IVC. You can identify the portal. It is posterior to the portal vein, hepatic vein drain to the distal part, and then it is passing the diaphragm and then the right atrium. CT scan is one of the most important modality. It is used to identify identify the IVC, which is located just right to the aorta, and The suprarenal gland is located posterior to it, sometimes part of the liver, and also maybe see the right renal gland is partly posterior to it. The liver tissue maybe see the right aortic branch passing, sometimes passing through that may be visible, and the union of the common iliac vein are seen in the coronal section, just posterior to the common iliac artery. Also, MRI also can be, the IVC can just be, and tributary can be non-invasively visualized a few coronal and sagittal section without the need of the contrast. Vein of the posterior abdominal wall, it is, there's a rich venous anastomosis in the lumbar area via segmental lumbar vein, which is drained directly into the vena cava and ascending lumbar vein and diagonal vein. This system usually has the communication with the left renal vein, with the internal and external vertebral venous plexus via the small vein, and communicate to the has communication with the IVC. The lumbar vein are joining sequentially in both sides of the vertebral column by the ascending lumbar vein, which is also extending further to the lateral sacral and iliosacral vein. The iliolumbar vein also joining into the common iliac vein. The ascending lumbar vein ascend on the vertebral body just at the root of the transverse body to the psoas muscle and extends further to the azygos vein. This is the diagram show the this is the lumbar vein with iliolumbar vein sent downward, and that with lateral sacral vein, or it is ascending lumbar vein going to the azygos